Hello, this is Dr. Graham Reynolds from the American Institute for Cognitive Therapy. Today we are going to be talking about treatment for substance use disorders. So to start, we have a chart here taken from the National Survey on Drug Use. This is past year substance use disorder in the United States based on percentages. So if you look at the right-hand column, this is what we typically conceive of as adults 18 plus. And percentages, so 2.7% of people in the United States, 18 and older, using illicit drugs. If we look at alcohol use disorder, 6.9%. Any substance use disorder at all, 7.93%. So about 8% of people are meeting criteria for substance use disorder in the United States, according to the data from 2015-2016. Now, what's particularly interesting is when you start looking at the statistics about people who are needing treatment but not receiving treatment. Unfortunately, there is a very significant treatment gap in the United States, such that only about 10% of people who need treatment for substance use disorders are actually getting that treatment. So there is a very real demand and need for substance use treatment. I think with that in mind, it is important that we are doing substance use treatments that work, and there are a lot of options for substance use treatments that work. So, to give you some of the hard numbers, this is going back a little bit further in time, but in 2013, an estimated 22.7 million Americans, about 8.6% of people, needed treatment for a problem related to drugs or alcohol, but only about 2.5 million people, about 9%, are receiving treatment at a special facility. So again, that's hovering right around the same number. 10% of people who need treatment are actually receiving treatment. There are a number of evidence-based practices for substance use disorders. This is taken from the APA guidelines about evidence-based practices. It's studies and research that has come together to show that these different treatments do work. It's not just sort of that we think that they work or, trust me, they do. These are well-controlled studies that prove these treatments work better than just, say, supportive therapy. Some of the big ones include motivational interviewing, motivational enhancement therapy. Those two kind of go hand in hand, and then often that can be combined, motivational enhancement therapy plus cognitive behavioral therapy for substance use disorders. And there's very strong research support that that is efficacious. It works. Similarly, we have seeking safety, a skills-based approach for PTSD and substance use that also has strong research support. Prize-based contingency management, couples therapy, friends care, and guided self-change. And we'll talk about each of these in turn. So to begin, we have motivational interviewing, MI, motivational enhancement therapy, MET, and then MET plus CBT, cognitive behavioral therapy. This is designed to increase a person's motivation for and commitment to change. It is a short-term intervention that is very much targeted on getting people in a readiness phase to make a change in their life. The great thing about MI and MET is that even on these short scale, we have found that it can reduce drinking or other problematic drug use. Oftentimes, though, the best approach is that when you're combining these things with cognitive behavioral therapy, it's almost like motivational interviewing is getting people to start talking about why they should change, and then you can come in with a cognitive behavioral approach to figure out how they actually go about doing those things on a real scale. Motivational enhancement therapy is contrasted with motivational interviewing. It's designed for clients who are maybe less ready to change. It's creating a little bit more ambivalence. So somebody who's saying, I don't want to stop drinking, I really can't stop drinking, I have no interest in changing. Motivational enhancement therapy might be a good first approach. It's just starting a conversation about what might be the downsides to continuing to drink and what does that look like for you. These interventions, as I said before, can be useful even on their own. So as short as 1 to 4 sessions, we can start to see reductions in alcohol or other drug use. A recent large study looked at various treatment interventions, including motivational interviewing and cognitive behavioral interventions. And what they found was patients who are receiving naltrexone, a medication designed to cut cravings for alcohol, plus medical management, another group of cognitive behavioral intervention, CBI, plus medical management and placebos. So no actual medication here, but just going for regular doctor's visits and getting cognitive behavioral therapy. And then a third group where they were actually getting the naltrexone to cut cravings, plus medical management, plus cognitive behavioral interventions. That these three groups had higher percentages of days abstinent than those who were only getting placebos or only just going for regular doctor's visits. And in essence, what this means is that cognitive behavioral therapy can work really, really well with medical management. It's important in substance use treatment that there's almost a team approach, a collaborative approach between psychologists, psychiatrists, other people who are involved in perhaps detox processes or other medication management, social workers, family members. Any of these people can be involved in the life of somebody who's struggling with drug and alcohol abuse, and hopefully can come together to get the person some help. The next approach is seeking safety. This is designed for substance use disorders and PTSD, and the research that we have shows that seeking safety is pretty good for treating substance use disorders and good for treating PTSD. So the evidence is that there's pretty good effect sizes for PTSD, a little bit less of a large effect size for substance use, but it is still efficacious. This does still work. And in essence, seeking safety is a skills focused. It's talking about alternative behaviors, other things that one can do instead of drinking or using drugs as a way of coping. A lot of times people who are using these substances are doing so as a way to manage emotions, and seeking safety provides some alternative skills that might be helpful in situations like that are more adaptive. And within seeking safety, there are a total of 25 content areas for handouts and guides, so it's a treatment approach that is really hands-on and skills focused. The other EBPs, or evidence-based practices, prize-based contingency management. This is for people who are basically being reinforced. They're giving rewards to people for sustained abstinence, coming up with urinalysis and clean drug tox screens. They can be offered prizes ranging anywhere from $1 to $100 in value, and we find that for people who are heavy chronic users, sometimes this is a great incentive, especially when combined with other approaches, to keep people off of drugs. You're rewarding them for staying off of drugs and alcohol. With behavioral couples therapy, this is for alcohol use disorder specifically, so it's not necessarily for all different substances. I would imagine it is probably efficacious for all substances, but where we have the data, what we can actually prove and say this works better than run-of-the-mill therapy, is with alcohol specifically. I think it's fair to say that incorporating families is an absolutely essential part of treatment, because you really need to get into the person's environment and figuring out what's going on around them. Having family sessions and education sessions for family members who are also struggling with a friend or a loved one's drug use can be a really important intervention. With behavioral couples therapy specifically, you're using CBT techniques to work with both people, both the person who is using and their partner, to reduce use. This is things like changing cues, managing your environment, increasing support, and really reinforcing, again, rewarding that sustained abstinence. Friends Care is a 6-month aftercare program in community settings. A lot of times Friends Care can be helpful for people who are transitioning from maybe a rehab setting or a more intensive setting to then going back to the community. They need a lot of supports in that time. So this is a focus on case management and also offers people access to crisis management. It's really kind of saying, if you feel like you're tempted to use, here's some supports that you can call people. There is also guided self-change, which is designed for people who are maybe not in severe use, but really want to make a change. Guided self-change is incorporating aspects of cognitive behavioral therapy, motivational interviewing, other relapse prevention strategies, and facilitating with a therapist in order to create this change. Cognitive behavioral therapy is obviously one very efficacious approach. There are a number of different ways of going about treating it. Cognitive behavioral therapy from a cognitive restructuring standpoint, monitoring and managing cues for drinking and wanting to drink alcohol or use drugs. There are mindfulness-based approaches to treating alcohol abuse, and even dialectical behavior therapy can be used and applied for substance use disorders. In addition to that, and often some of the more popular or well-known interventions for substance use is either AA, Alcoholics Anonymous, or NA, Narcotics Anonymous, but there are some alternatives to that as well. Alcoholics Anonymous has a long history of really being a go-to approach for substance use disorder treatment. People who might be court mandated or otherwise needing help and just self-selecting and wanting to go on their own can get assistance for their drug and alcohol problems through the AA and NA programs. Sometimes people have issues, though, with aspects of AA and NA. In particular, there is an involvement of this idea of surrendering to a higher power, and that may not sit so well with some people sometimes. As a result, there have been now alternatives to AA and NA that are also proving to be pretty efficacious. Some long-term studies are finding that women for sobriety, secular recovery through LifeRing, and what's called smart recovery are great setups that are similar to the AA-NA model of supports and community resources, but without the higher power or perhaps religious aspects that sometimes people have a hard time with. And finally, we have pharmacological treatments for different substance use disorders. FDA has approved drugs for alcohol use, opiate use, and nicotine use specifically. So treatments for alcohol include camprosate, which modulates GABA, the neurotransmitter involved in alcohol, glutamate, another neurotransmitter in the brain, and essentially what it does is it decreases cravings for people. We also have disulfiram, which is branded as Antabuse. Essentially, this is a medication that will make somebody sick if they consume alcohol. You take the medication, it doesn't automatically make you sick, but if somebody were to take the medication and drink alcohol, it creates a negative reaction that makes somebody feel physically ill. That can be an effective deterrent. Essentially, what's happening for people who are taking Antabuse is that if they drink alcohol, they'll feel very sick, and that is not a great feeling to have, and therefore can reduce the use. Finally, there is naltrexone, which will show up again later. Naltrexone was originally designed as an opioid treatment, but we found that using it for alcohol can be effective as well, especially for decreasing cravings. Now, for the opioid treatments in particular, we have buprenorphine, which is marketed as Suboxone. It is increasingly popular and a very good drug for managing opiate abuse. It's a partial agonist, which means it basically kind of eliminates some of the withdrawal symptoms that people have with opioids, but it's not acting as like a method for people to get high. So it's similar to methadone, but without some of the negative side effects that methadone may have. Methadone, again, is an opioid agonist, so it's an opiate with lower abuse potential than, say, heroin or prescription pain opiates. Naltrexone, I mentioned, in this case can be just taking away the rewarding effects of opiates. And naloxone is a fast-acting version, very similar chemically to naltrexone, but it's really designed for preventing overdoses. It's becoming increasingly popular and common for people to have naltrexone inhalers on hand in case they need to be in a first responder situation. And finally, our nicotine treatments. We have bupropion, which is essentially low doses of the brand named Wellbutrin. In larger doses, it's marketed as an antidepressant, but in low doses, we found that it can help cut cravings and withdrawal symptoms associated with smoking. There is varenicline, Chantix, which can reduce the cravings and withdrawal, and then finally there are nicotine replacement therapies. These are the traditional gums, patches, nasal sprays, inhalers, lozenges, other things that people have. They're actually getting a little bit of nicotine, but not in the smoking form as a way of quitting. And that's all we have for substance use disorder treatments. Thank you again. I'm Graham Reynolds from the American Institute for Cognitive Therapy.